Oh, yep. Yeah, I'm just gonna hit record. We've got 15 folks joined in. Hi,
Okay.
everybody. I'm the project manager for Heartland, and since we're on time to get started, I think we should start it off. Right before we do, though, just on behalf of Heartland, want to thank Joanne and our hub team for putting all this together. So, having said that, I'll share my screen to show the agenda, and it's all yours, Joanne. So,
Okay.
thank you.
Can you also put up the disclosure form real quick?
Yes.
Yeah. As Kara's mentioned, I'm Joanne Bolick, and I'm a consultant for Heartland to coordinate the ECHO newborn screening trainings. While she's getting that up, we have no disclosures to disclose. And we do have some free CEUs that we're going to talk to you about for physicians, physician assistant nurses, and genetic counselors. And Kara, thank you for putting that up there. In case you're wondering what ECHO stands for Extension for Community Healthcare Outcomes. And it was created over 20 plus years ago by Dr. Sanjay Arora. He's a gastroenterologist at the University of New Mexico Health Sciences Centers, and it was created for the purpose of promoting and creating access to healthcare for patients within our community. The ECHO series is entitled Helping Babies Get Off to a Good Start. And our first talk is on congenital hypothyroidism, which is the frequently misunderstood screen. And this condition has been around a long time, but Dr. Schaefer is going to share with you more about it. But before we do, let me introduce our hub team. I'll just say their names. We don't have time to do any more than that. But here is our IT expert. Our ECHO expert and accreditation expert is Gail Hahn. Kenneth Kersey was our laboratory expert. Pat Fox, patient advocate expert. Dr. Schaefer is our medical director for the 3 series. Our short-term follow-up representatives is Crystal Baumeret and Jamie Kiesling. Our long-term follow-up expert is Amy Burke. Our genetic counselor expert is Chelsea Zimmerman, and I'm facilitating today's session. The educational training for newborn screening was based on 2 surveys that were sent out. And the leadership looked at these 2 surveys. We discussed it along with the ECHO Hub team, and that's where we came up with these 3 conditions. 2 of them are old conditions, and what I mean by that is we've been screening in the United States for congenital hypothyroidism, cystic fibrosis for a long time. But the third one is one of our new conditions, MPS 2, and it'll be offered in our 3rd month, which is in March. The ECHO training emphasizes an all-learn, all-teach model. We have a brief introduction, which is what I'm doing now. Then we have a didactic session with Dr. Schaefer, and he's going to talk about the medical aspects of congenital hypothyroidism. And then Jamie Kiesling is going to do our case presentation. And then this is followed by the interactive venue of question and answer discussion time. And this is case-based, and it promotes best practices. And this learning experience is really geared for all participants. And this will be followed by a few minutes of closing remarks. I want to now start with a quick introduction of Dr. Schaefer and Jamie before I turn it over to them. Most everybody knows Dr. Schaefer, but in case you don't, he's a professor of pediatrics and genetics at UAMS and Arkansas Children's Hospital in Northwest Arkansas. He came to Arkansas in 2008 from Nebraska, and in Arkansas, he became the chief of genetics and metabolism section at UAMS and Arkansas Children's Hospital. And he held that position until 2017, when he moved up to Northwest Arkansas with the opening of the new Arkansas Children's Hospital. Dr. Schaefer is not only certified in medical genetics and pediatrics, but also he is certified in pediatric endocrinology. Jamie Kiesling is the chief of Bureau of Genetics and Healthy Childhood at the Missouri Department of Health and Senior Services. And Jamie has been in that position since 2018. Prior to that, she was the Missouri Newborn Blood Spot Screening Program Manager for 7 years prior to becoming the chief. And Jamie has a Bachelor of Science in Nursing degree from Lincoln University. I want to turn it over to Dr. Schaefer and then Jamie.
Cool. Quick question. So my slide is there as somebody going to advance that for me? Is that what's going to happen?
Kara can.
Kara will. Okay. Thank you. All right. So I'm the preface. Okay. I'm going to talk about congenital hypothyroidism as a condition, both physiologically and medically and treatment wise, and then the application to newborn screening. So that's what we're going to cover. Next slide. Disclaimers, I have no interest or financial conflicts to declare. I'm a geneticist, so you know I'm poor, and so nobody I know is rich, and you guys have to worry about them influencing me. So go back, please. So Joanne mentioned my training. So GEM is something that only 25 of us in the country ever trained in. So back in the early 80s, called genetics, endocrine, and metabolism, before these were separate fields. Back then, there was so little known in each of those fields that you could actually study them all. Now, of course, you know that they're divergent in different groups, but I have at least the background as an endocrinologist to do that. Talking about congenital hypothyroidism is almost as bad as a talk on fetal alcohol syndrome. That's one of my family jokes. My son-in-law had to drive me one time to a meeting, and he had to listen to a talk on fetal alcohol syndrome, which I don't think he's still recovered from. So this is not the most scintillating topic in the realm of genomics and genome sequencing, but obviously incredibly important. And for those of us that work in newborn screening, something that is very important for our patients and important for our systems to be able to deal with effectively. Next slide. If you were on earlier, you see my background there. That's Osage Creek behind me. This is where I live in Northwest Arkansas now, much prettier than Little Rock. And so this is where we are. It's the home of the Walmartians. Half the people here in Northwest Arkansas are not native Arkansans. It's a very diverse group. Interesting group of people. It's funny, I'll occasionally have a patient show up and I'll say, oh, you know, Mrs. Jones, I think, you know, your son has Soto syndrome. And she'll say, well, Dr. Schaefer, we're from New York and we sure you're okay geneticist, but we're going to go back to New York and see a real geneticist and get a good opinion here. And then they're back in my office in 3 months saying, well, my doctor in New York said you're the world's expert and I should listen to you. Will you see my son again? And so dealing with this part of the world is a fascinating thing. Next slide. All right, so the topic, okay, newborn screening, one of the, depending on which state you live, 32 to 38 conditions you screen for. One of the earlier ones, congenital hypothyroidism, the term simply means at birth, the thyroid isn't working the way that it should. And so again, the thyroid hormone, as we'll talk about in just a second, is critical to normal physiology. And so an underactive thyroid gland is something that's a problem. Endocrine wise, of course, you know that on our panels, most of us have congenital hypothyroidism, and then you have adrenal hyperplasia. Hypothyroidism is the more common of the two. It's the most common inborn disorder of the endocrine system. So newborns with endocrine problems, most commonly it's going to be these patients. Again, Arkansas runs 40,000 live births a year. So again, a condition one every 2,000 or so. That means we have, you know, a handful of kids every year born with this condition, and nationwide it works out to be about the 1,400 cases. And to this day, despite screening and treatments and that sort of stuff, we still get kids that run into problems with this. Next slide. All right, I'm not going to read these slides to you, nor do I think you need to understand and remember your training days and try to worry about this. But the major thing to talk about from the embryology of the thyroid gland and why it's important to know about is that it's an organ that starts again in the region of the pharyngeal pouches. It starts as basically this outpouching of the endoderm, and then the tissue forms around that. As you can see, I guess you're not seeing my slide, you're probably seeing Kara's arrow. But if you look at basically on the A diagram there, you see the little red dot there, that's the thyroid gland sitting down basically in the equivalent of probably just above your clavicles there. And then it moves upwards as the craniofacial complex grows. It moves up, and then it goes to basically just below your chin. And again, most of you know where your thyroid is, sitting right here. It's a little butterfly-shaped organ. Someone who is not excessively overweight and has a big thyroid, you can physically see the proverbial butterfly sitting on the neck of the person. And so again, you can see that this is typical embryology, where the first trimester is where all the action happens. After the first trimester, then the embryo or the fetus just symmetrically starts getting bigger. So in theory, by the end of the 10th or 11th week, right at the end of the first trimester, the thyroid gland has formed and it has migrated up to the position that it's going to keep. Next slide. All right, so the physiology of the thyroid gland is kind of walk through these relatively quick, but just to make sure you understand, is that out of the thyroid gland comes two hormones, T3 and T4. For whatever reason, the way our systems are designed, what the thyroid primarily makes is mostly T4, and then the T4 is peripherally converted into T3, which is the active form. Okay. The thyroid does its work under the control of the pituitary gland. So the pituitary gland making its 8 hormones. One of those is TSH, which is thyroid stimulating hormone. The term self-explanatory, it stimulates the thyroid. It tells it, make me thyroid hormone. And it makes it in the classic endocrine, what we call feedback loop, right? So that basically the pituitary gland can sense how much T3 is floating around in the system. And if the levels start dropping, if the levels are below what the pituitary gland thinks that it wants or what your body needs, then it'll release TSH. TSH will go down to the thyroid gland and then tell it to make more hormone. As more hormone is released and feeds back onto the pituitary, then once the pituitary gland is satisfied that it's got the right amount of hormone in it, then the TSH is suppressed and no longer will be there. Also then, pharmacologically, if you give someone enough thyroid hormone, then their brain doesn't need to do anything with that because it's sensing all that's out there. And so you'll basically see low to even undetectable levels of TSH depending on how much hormone the person's been given. The whole point about this is, what does the thyroid gland do? You see my little term up there. That's what I always tell my patients. I liken it to the rheostat for metabolism. Okay. And so basically your entire body metabolic rate globally is basically regulated by thyroid. Okay. It basically, as thyroid hormone goes up, everything related to anabolism happens. Oxygen consumption goes up, you breathe faster, your body temperature goes up. And so again, it's basically a metabolic stimulant. I'm sure you guys have known somebody in their time who got hold of a weight loss doctor and they magically lost a lot of weight. And then you figured out what they did is they treated them with thyroid hormone, basically gave them a disease, gave them hyperthyroidism, and suppressed their weight. Not a good thing. There's lots of good data out there now that for adults, a suppressed TSH situation actually puts people at a much greater risk of strokes. And so it's really not a good idea to drive this system down. Again, the second bullet there, it stimulates metabolism, carbohydrates, anabolism of proteins, may in high enough doses, as we said, could get hyperthyroid and actually kind of burn stuff off too fast, and then may indirectly influence fatty metabolism. The final bullet there, reverse T3, is a way your body has of activating T3. There are certain times when your body says, I don't want my metabolism revved up. And that's usually during times of severe disease. And so sometimes we see kids like in the ICU and those sort of things in which the body basically takes most of the thyroid hormone and converts it to reverse T3 so that it doesn't cause them any sort of metabolic upkeep when you're trying to basically survive whatever this crisis is. So again, TSH stimulates the thyroid to make T4. T4 gets converted peripherally to T3. T3 does its magic. Again, what a definition of a hormone is a substance that's made one place, sent into the blood to go work its magic in other places of the body. So this is a typical hormone system with its feedback. Next slide. All right, so again, on the right column, I just put other because there's reasons other than what we're talking about that can cause people to be low on thyroid. There's autoimmune thyroiditis where you get either Hashimoto's or those sort of things, and your body's attacking the thyroid. Tumors in the pituitary gland. Sometimes it's removed because of nodules and those sort of things. Certain medications can suppress it. And then iodine is a primary component of thyroid hormone. In fact, it's the only organ in the body that uses iodine. And so again, those of us that are really old, you may remember when there used to be salt without iodine in it, right? And so again, one of those public health victories and supplementation, that sort of stuff, is still the fact that iodine is placed into salt so that people don't run into an iodine deficient diet. So that's the other stuff. What we're focusing on is the congenital part on the left side there. The most common reason that a baby does not have thyroid function is because there's something wrong with the gland. Okay, back to that physiology or the embryology we talked about. The gland has to form and then it has to move into the right place. For some reasons, and there are genes that are known for that. I'll talk to you in a minute about that. Sometimes there's a genetic change that causes the thyroid gland just not to form. Sometimes it's smaller than it should be. And then sometimes it can be what we call ectopic. Okay, so again, you looked at that picture of the embryology starting down low, migrating superiorly. Sometimes it just doesn't get up to where it's supposed to be. And where it's at really doesn't matter. But the point being is that if it didn't migrate up, it usually means there's something wrong with the way it developed and it's just not doing what it should do. That's what we call primary. The thyroid gland itself is deficient and can't make the thyroid hormone. Secondary, or what we call central hypothyroidism, is when the problem is not in the gland itself, but in the pituitary gland. So the TSH is not being released, not telling the thyroid what to do. And then lastly, rarely, again, just like any other metabolic situation, there is a metabolic pathway where you start and synthesize and construct thyroid hormone through a series of enzymatic steps. And like any other metabolic condition, if there's an enzyme deficiency, it can interrupt the synthesis of thyroid hormone. And so there's a small number of babies who are born basically with the inability to actually make the hormone itself. Okay. All right. Promise I'm not going to read the whole thing to you here. Again, I don't know what the rules are with Echo, but Kara, my slides are non-proprietary. You can share them if anybody wants them. So anyway, just the bottom line being is that it's an interesting thing. If you're revving up or revving down metabolism and it's affecting everything, it can do most anything, right? And so again, so that when you think about it, underactive thyroid, you're slow, you gain weight, your hair doesn't fall out, you feel cold all the time, all those sort of things. All right. So again, I'm slow metabolically. You see over there in the adult line, constipation, dry skin, weight gain, puffy face. I know what you're saying looking at these images. You're saying Schaefer needs his thyroid checks. So but you can see what happens when your thyroid gland doesn't work so well. Feeding and growth problems in the kids, poor weight gain, constipation over there again. And then in the middle between infants and children, similar things, but adults are done growing, kids are still growing as our teens, and so growth and puberty are something that we think about in the teens. Next slide. All right, just a couple pictures. You can see again, my endocrine days were 40 years ago, but here's some pictures from my training days. Baby on the left has untreated congenital hypothyroidism. Sometimes in the vernacular, people have called this cretinism. that's what they're referring to, where the term Cretan came from the island of Crete. And then there was, again, interesting history there. But the bottom line is they thought that these kids had that kind of overall coarseness and those sort of things. The little girl on the left has acquired hypothyroidism. This is what happens when you're born with a normal thyroid, but then it gets burned out and nobody knows it. And then suddenly the kid quits growing and developing and all those sort of things. Next slide. Treatment is one of the easiest things in the world. You're missing thyroid hormone, you give it to them. All right. I will not get into all the nuances. Again, if you guys are clinicians and take care of people, you'll know that there's some people that are completely convinced that the standard synthetic thyroid medications aren't as good or aren't as absorbed and sometimes need to be treated. The bottom line is, for the vast majority of people, straight levothyroxine, a synthetic T4, works like a champ. Cheap, non-toxic, and unless you take too much of it, you're not going to get in trouble. There are some people who for some reason can't tolerate that. Other people who like, quote, natural stuff, and so it's possible to actually use desiccated thyroid, right? Go out to the slaughterhouses, do thyroid extracts. You can give them the thyroglobulin, which is the carrying protein. And then there's actually, for some people, for whatever reason, the peripheral conversion from the T4 to the T3 doesn't seem to work as well as it should, and so you can give them directly the T3. Other than just giving the medicines, you just monitor things, right? These are, again, particularly we're talking about congenital hypothyroid. These are kids. They're going to grow. Their doses are going to change with weight, and you're going to have to just keep up with those things. Next slide. Newborn screening, Joanne already mentioned, one of the earlier conditions we screen for. We started doing that in the early 70s. Different states have chosen different methods. Not sure why, but some tests for just the TSH, others just the T4, followed by the TSH, and some do both. Values are set up by each state in its own cutoff values. So if you notice, your state cutoff is a little different. Each state has their own advisory committee that is, picking numbers for whatever reason. In theory, it's all done by monitoring the ongoing data and adjusting and tweaking those. Next slide. Once the kid's diagnosed with congenital hypothyroidism, then we go after which cause is it. May have to image the thyroid, check antibodies, look at iodine, may even have to do x-rays of the knees, which help us look at how advanced the hypothyroidism is. Next slide. This is a radionucleotide slide. And again, this is from the old days. This is back in the 80s. But basically, on the left there, you see that black dot. That's the thyroid picking up the radioactive iodine. And what you can see that what you're seeing is you're looking at the head from the back. Can you see the head and then the neck and then the shoulders? And what you see is that glowing spot is below where that dot, that X is, or that arrow or cross, or whatever we call it, which is where the thyroid should be. Okay, so this is an ectopic thyroid gland. It just hasn't made it all the way up. Next slide. I won't read these, but if you guys want them, there's the diagnostic algorithm actually can be quite difficult, and the genes that are causing these different processes are being worked out. So again, most commonly, once a diagnosis is made, we can do genetic testing. Next slide. And depending upon whether the TSH is up or normal, there's different algorithms, different genes involved. But again, we can be looking for the specific causes of the thyroid hormone deficiency. Next slide. The big issues, time is one. Okay, so this is not like galactosemia, where the kid's going to get sick in the first 2 or 3 days and it's going to be dramatic. But what's been documented incredibly consistently is that beyond 16 days of non-treatment, you can begin to clearly show decline in IQ scores and IQ potentials. Okay, so this is just the bottom line is that we want to. The whole reason it's on the panel is because it meets all those definitions of if I find it and fix it, then the kid will do fine. If we don't figure it out or start treatment by 16 days of life, we're in the category of we should have done something quicker. Like CAH and several of the other newborn screening conditions, prematurity, big issue for hypothyroidism. The transient type is much more common in preemies and low birth weight infants. And any of you guys that deal with newborn screening, you know that the bane of our existence for CH is the premature infant, and trying to sort that out and trying to keep the neonatologist on schedule and those sort of things. Next slide. Follow-up, short-term follow-up is just, again, get the kid on thyroid, and then somebody who understands the condition should follow them. I'm going to give you my bias. Could a PCP do this? Probably could. Most of them don't do this regularly. I strongly suggest that the child be put into the care of a pediatric endocrinologist for the first few years of life. Once the kid kind of hits that, linear growth stage and everything's good, I think the care can transition to the PCP. But in general, I think it makes the most sense to at least let a ped endo person follow them early on. And then lastly, long-term follow-up. There's a reason that there are, federal initiatives for newborn screening, long-term follow-up. Lots of unanswered questions about the long-term effects. Joanne and I have worked on this for getting close to 12 years. And sometime in the near future, we're going to start breaking out the codes and the data and start looking at long-term outcomes for these things. We're following all the newborn screening conditions. Don't have any notes for you right now for hypothyroid, but one of these years, probably when I'm retired and can work on this, we'll start publishing the papers on our 12-year experience of long-term follow-up for newborn screening. Next slide. And I'm done. Kara, did I make it in time?
You did a wonderful job. Good
All
job.
right.
Thank you. Very informative. I learned a lot. So thank you for that.
Kara, you're muted.
Oh, you can't hear me?
I can hear you, Kara.
Yeah, me too.
Okay.
Okay. Well, Jamie's
Are you
up.
guys hearing her? Is it just me that's not hearing her?
It's just you. Can you
Don't
hear
hear-
anyone? Oh,
Can
go
you
ahead.
hear any of us, Brad?
Well, I'm just not hearing her, but
Can't
that's
hear
okay.
anything. I don't think.
If you guys are hearing her.
Are you hearing everybody else, sir?
Okay,
Okay.
thank you.
Thank you, Dr. Schaefer. Jamie, please go ahead with your case presentation.
All right, thank you. So as Joanne mentioned earlier, my name is Jamie Kiesling. I'm with the Missouri Department of Health and Senior Services. And I am going to run through a case presentation with you today. So for this case presentation, we are looking at a newborn who had an initial newborn screen collected on the second day of life at about 36 hours of age, which is within that normal time frame of recommended collection for newborn screening, between that 24 and 48 hour time frame. So the blood spot specimen was received at the state public health lab on the third day of life, with results reported out on the seventh day of life. This newborn had TSH results at 55.7, with the normal range for this state, for this screen, is less than 25. And then the T4 was 10.2, with the normal range being greater than 10.5, which is the lowest 10% of the day's run for this public health lab. Additional information that we have on this baby, based on what was provided with the newborn screen, was this is a term baby at 38 weeks, single gestation, just shy of 3,000 grams, and this baby is breastfeeding. So this child had confirmatory testing collected on the 8th day of life. And when this baby was brought back in, this confirmatory testing showed free T4 at 0.7, which is still a little on the low side, and TSH at 28.2, which is also outside of normal for this child. At this time, the primary care provider consulted with a pediatric endocrinologist by phone. The endocrinologist recommended another set of confirmatory testing to reevaluate, since the TSH had decreased, but was still considered too high for a newborn. So that second set of confirmatory testing was collected on the 14th day of life, still outside of what would be considered normal for this child. So the endocrinologist at this point recommended starting treatment and referred the baby to pediatric endocrinology for a further follow-up. So this child was diagnosed with congenital hypothyroidism at 15 days of life, and treatment was started at this same time at 15 days. So this child followed up with pediatric endocrinology at 20 days of life, and at that time they went ahead and did some repeat labs, which would have been about 5 days after the initiation of treatment. And here you see the T4 is within normal range, as well as the TSH. So for this kiddo, they returned for follow-up at 2 months of age, and then they were seen about every 2 to 3 months until a year of age. And then after that point, about every 4 to 6 months until 3 years of age. And so then when we're looking at long-term follow-up data for this child, we find that they were reevaluated at age 3. And based on labs at that time, the endocrinologist recommended that that child go ahead and remain on treatment for life for congenital hypothyroidism. All right, so that wraps up the case study. So I'll let Joanne, do you want to open it up for discussion?
Thanks, Jamie, and thanks, Dr. Schaefer. Yes, I want to open it now for group discussion and comments. Please feel free to share your questions either verbally, or if you want to, you can put your comments under the chat section. You can type them in there, whatever you're comfortable doing. So I just checked. We don't have anything in the chat right now during the presentation. Anybody in our audience have questions for Dr. Schaefer or Jamie?
I have one, Joanne. So I'm just curious. This is a question for Dr. Schaefer. So in the case that Jamie presented, they just determined it was your garden variety, low thyroid function. I'm assuming that the endocrinologists, when they evaluate a child, they're going to do more specific testing to figure out which one of those mechanisms, or do they? And then my second part of the question is genetic testing routine these days with congenital hypothyroidism, or only in special cases? I'm just curious. This is not something I really know anything about.
No, I mean, both questions are appropriate. So the first one is, yes, that's part of the thing is that, once newborn screen says there's congenital hypothyroid, then like I said, then the endocrinologist should do the workup, because again, there's a difference between, is it, a thyroid hormone problem, a pituitary problem, end organ, whatever. So, or an ectopic gland, all of that. So there's a formal workup that should be done. The newborn screening just saying it's congenital hypothyroid, then somebody's got to figure out which of the many different variants it is. I'm a genetics person primarily, as you know. So the answer is, if I see a patient with congenital hypothyroidism, I will do genetic testing depending upon the type and those sort of things. Most endocrinologists aren't doing those. So they're just, they're just going to say it's, gland's not there. We know why you got hypothyroid, treat it, and we're done. But as you and I know, there's the cool question of, why is the gland not there? And so not only is that the problem, but what's the etiology? And for all those reasons that we in genetics do what we do, I glibly tell my patients I call myself the why guy. So we like to figure out why, and then again provide information about family issues and the whole things that geneticists do.
Thank you, Dr. Schaefer. Other questions from the participants?
Dr. Schaefer, I have a question for you. When in your presentation, you talked a little bit about transient CH. Can you talk a little bit more about how that treatment plan or that follow-up plan might differ in those situations versus more the classic CH?
Right. So yeah. So the point being is that recognize that once you put the child on thyroid hormone, then labs are going to be, non-diagnostic, right? They're going to be reflective of therapeutics rather than diagnostics. And so the thing about it is that if you have the baby, TSH is high, T4 is a little low, you start treating, where do you go from there? If it's a term newborn, likely it's the full thing, right? But what you're going to say is that if I'm dealing with a low birth weight or a premature infant, the chances that this could be transient are much higher. And again, then what you will do is you will, or what I will do, and everybody's a little bit different, but I will usually treat for a while, because again, the most important thing you want is to make sure everything's revved up, the brain's good, that sort of stuff. But depending upon how things go, it's not unreasonable at all down the road to give them a challenge, right? Very short period of time, you stop the thyroid hormone, see if you don't get normal values, and then you may just be able to be done with it, right? And you just say, again, the whole thing about prematurity with newborn screening, not just thyroid, is guess what? 22 weeks, think about that, a 22-week baby, that's halfway through pregnancy. There is so much stuff that hasn't happened developmentally, right? Liver maturation, which affects all those metabolic enzymes, and organ growth, and even some of the things like with the thyroid particularly, I think is related to probably neuronal networks, right? So that whole process of how the hypothalamus has to talk to the pituitary, which has to talk to the thyroid, and those sort of things, those neural networks, they have to be matured, and they have to be wired, and then they have to be myelinated. And there's just stuff that hasn't happened in these micro preemies particularly. And so again, that physiology is something that we've never had to deal with before. I mean, when I was a resident, we were ecstatic over a 29-weeker that survived, and now it's survived and all this sort of stuff. I mean, literally, if the thought of surviving at 22 weeks gestation is unbelievable, but that baby is so different than a term. I mean, I'll get off on another tangent, but even when you start looking at cerebral palsy, right? The brain is so different that what happens to the brain of a 22-week-old is nothing like what happens to the brain of a 40-week gestational baby. So really long answer to say that because you can have a much higher chance of it being transient, if it's a preemie, oftentimes I'll treat and then give them a challenge down the road and see if they still need it, if they're going to need it lifelong or not.
Perfect. Thank you.
Thank you, Dr. Schaefer. Any other questions from the participants?
So Dr. Schaefer, can you talk about when you would recommend a T3 be ordered? Because a lot of confirmatory testing, they do a free T4 and a TSH. However, sometimes endocrinology will say, oh, let's do a T3.
Yeah, again, the T4 is the easier to test for, and it is what the thyroid makes. So that's kind of why we test that. The reason for doing a T3 would be if something's not making sense. Okay, so you say I've got I'm giving them medicine, T4 looks good, but the kid's growth is plunking along. They kind of look a little clinically hypothyroid, and you say, this doesn't make sense. Then you can go ahead and check a T4 and T3 and see if in fact there's some sort of problem with peripheral conversion. Okay, I'm giving plenty of T4, but it's not getting converted. That's back to that slide with the potential treatment with T3, is that there's a small group of people that have the problem with the conversion. And so giving T4 isn't going to help. And so then you bypass that by giving straight T3.
Thank you, Dr. Shaver and Crystal, for that question. Other questions? I think Lori has another one. If there are no other questions from anybody else, Lori, go ahead.
You've got your one.
I've got a list, Brad.
You can have 2 or 3, Dr. Shaver.
So this one is for Dr. Schaefer and Dr. Corsi. You may, it's also for you. So we know in Arkansas, among the Marshallese babies, that congenital hypothyroidism is the most common condition that they get an abnormal screen for. Do we know if their mechanism, is it just kind of the garden variety? Do we know any genetics on, I mean, has anything been done to sort of look more deeply at that? And do we know why? We know the thyroid's very sensitive to radiation, but these are babies being born here. So I'm just very curious about that. And if Brad in Arkansas, if you and Laura have talked about that, or if Dr. Corsi, if you have seen that in Iowa.
Well, as you know, we see a lot of patients from Marshallese extraction here. The easy answer to your question is, yeah, it's got to be genetic, right? I mean, the genetics of this population are so fascinating. I mean, you just don't do a microarray on a patient from the Marshall Islands and not usually find something, right? Some regions of homozygosity and those sort of things. And so the fact that it is much more common, no question, there's a genetic predisposition in that population. I don't think you can attribute it to the radiation exposures. I think we're too far out from that. Although some people still wonder, what's out there. It depends on, when they moved or where mom was when the eggs were formed or whatever.
Right.
But most likely, again, that kind of diagram I showed you before with all those different genes, that was from a GWAS study. And I can't remember, I read the article for this thing, but I can't remember, but I think they thought they could account for maybe 50% of the genes that cause congenital hypothyroidism, which means there's still tons of them out there that people don't know about. And so who knows what else could be in this population. So it'll be a fascinating study to do, but nobody's done it. And all we know is what you've already said, which is that it's more common in this group.
Thank you.
Okay.
I would add for Iowa, we don't collect that data. We don't collect race data in Iowa, so we don't have a way to break that out among our population. That's something we're working on adding to our forms going forward, but this time we don't.
Yeah, that's right. I'd forgotten that. I keep thinking because the adding has been talked about for a while, so I'm like, oh, maybe one of these days. So.
It's in progress. It was part of the Propel grant we're working on as part of that.
Good. That's right.
Other
Thank you.
questions? Oh, go ahead.
No, I just said thank you.
Oh, okay. Thank you, Dr. Schaefer and Kenneth. Any other questions from other participants?
So Dr. Schaefer, I think, this, is probably one of the more simpler, treatment wise, one of the, simple treatment plan for the disorders that we see in newborn screening. But do you still run across families every now and then who are reluctant to put their newborns on medication? Can that be a barrier sometimes? And if so, how do you address that?
Well, I mean, there's the easy answer, which is people can screw anything up, right? I mean, biotinidase deficiency, same thing. I mean, two simple conditions to treat, right? Give them biotin, give them thyroid. And the biotin, you don't have to even follow levels, right? And yet patients will mess it up. And so the issue isn't the treatment, the issue is compliance and understanding and those sort of things. And Jamie, if you can figure out how to make patients compliant, you should write a book and retire. So because again, the stuff they do and the ways they figure it out, and I mean, literally, I had a guy from Southeast Arkansas who was actually a pig farmer who was actually cutting out the thyroids from the pigs he was growing and grinding them up and giving it to his kid. And so,
oh my goodness.
Yeah, that kid did not like mom's pudding. So anyways, but so, and I'm being just only semi tongue in cheek. I mean, the problem is literally just, yeah. And I mean, it's like anything else. Hey, they said he's low on thyroid and they gave me these pills and they said one's going to help him. I bet 3 will really help him, right? And so, but the short answer is that treatment is usually very effective and very simple. Those rare cases, like I said, of some of the conversion stuff or some sort of secondary disease, that's what you pay the endocrinologist for. It's kind of like, delivering a baby, 95% of the time a cab driver in New York can do it, but we pay the OB for that 5% where you really need the expertise. And so so it's the same thing there, is that most of the time it's a no-brainer, but they'll throw you curveballs every time. And look for that. That's one of those 4 books I told you I'm going to write when I'm retired. I'm going to write some vignettes of some of my, a friend of mine, a pediatric neurologist in Arizona, and I are going to write a book and throw in some of our favoriteest stories. So stuff that'll curl your hair.
You'll have to let us know when it's out. Thank you.
Thank you, Dr. Schaefer. Any other questions? I have one thought, and I know you touched upon it, Dr. Schaefer, but that dishormonogenesis, if I'm pronouncing that right, I know in our long-term follow-up study, we saw a lot of kids that they would test them at 3. And if they had a normal result for 2 or 3 months in a row, then they would, you know, I guess, then they would discharge them from the endocrinology clinic. Other ones, if they continue to have a problem, then they would, you know, keep them on. Can you kind of talk a little bit more about that?
Again, it's just, you know, your algorithms are based on your statistics, right? And so again, the vast majority are going to have some sort of thyroid gland malformation. You just ride that tide. The ones that don't make sense, then you go further. Again, the dishormonogenesis ones are rare, but we get very excited about them because those are recessive disorders, right? And so there's the ones where you definitely want to, you know, be thinking about next children and all those sort of things. And so so you just don't want to let that go, and you don't want to make assumptions. But again, you run your algorithm headed towards what's the most common thing that's going to happen.
Okay, thank you. Other questions? I think Lori has another one. And she's allotted 3, Dr. Schaefer.
No, I've got 5. No, I didn't know, I didn't know I would have so many questions. That this has been a really interesting talk. So I'm thinking about at one point pre-COVID, there had been talk about moving toward a home monitoring approach for children with some metabolic conditions. And I'm thinking, unless, I mean, clearly there are going to be some people where if the treatment isn't working, they're going to need to be seen because there's, you know, probably some clinical issues and you're going to need to figure out what's going on. But this one seems like it would be a really perfect condition for most patients to be home monitored. You've got an easy lab test that can be done in the community for monitoring. You know, connect up, ask your assessment questions around some of the symptoms, you know, you'd be looking for if the treatment wasn't working. Does anyone on this call have experience with that being implemented in your state? I'm just curious if the metabolic home monitoring ever, or endocrine home monitoring ever really took off. I mean, it has for diabetes in some studies, but I don't know for this population. So I was just.
Well, you know, forever PKU, we've done that, right? Mail in your spots and that sort of thing. It works. And again, it's like everything else, you got, you know, your system has to be set up right with the good fail safes. The problem is TSH is a different sort of assay. It's not one that's real easily amenable to. It usually requires, again, either an immune assay or something like that, something that's not easily done. However, most of you guys are younger than me and Joanne there on the call, but if you're my age, you can remember the very first time that Star Trek came out and they walked up to the door and the door opened for them and you thought that was the coolest thing ever. And nowadays you walk into Walmart and it happens all the time. And so I am completely convinced that in 20 to 30 years, we're going to have little Star Trek tricorders and you're just going to be able to wave it over the kid's head and it's going to tell you what his TSH is and what his phenylalanine level is and all those sort of things. And so I think that people clearly have those things in mind, Lori. And I think, again, it's like Star Trek. You think about it, it's going to happen. People are going to get there. But right now it's given current technology, it's not doable. But again, I am so old that the first day of my fellowship, when we were doing that, we didn't even have radioimmune assays. We couldn't measure TSH. the way we monitored thyroid function was through a thing called PBI, which is a protein-bound iodine. And that was the blood test you measured to sort of get an idea of what their thyroid status was. So yeah, the technology will continue to evolve.
Thank
So, so we know, Dr. Schaefer, that, from my old years of early learning and doing follow-up for thyroid disorders, that we knew, if we had a baby with congenital primary hypothyroidism, the goal was for sure you had to have them treated by 6 weeks of age. And everybody was pushing, we were all pushing hard to try and get under the 10 days of age and all that. So a lot of the thinking, did that change from assessments, evaluations from the endocrinology world? Was it kind of driven by long-term follow-up data that came out of screening programs as well?
Yeah, I mean, definitely came out of long-term collaboratives. I mean, it wasn't as cool of a collaborative as the PKU collaborative, but again, people did look at collective data. That 16-day number didn't come out of nowhere. That again, there's, it's statistically just significant. Beyond there, you can do that. But the point being, Crystal, and this is where the real long-term follow-up is going to be helpful, has to do with if these things are congenital and present at birth and that sort of stuff, what is the process of being low during gestation? Okay, so think about your galactosemia babies, right? Why do, regardless of you screen them, they never get exposed to galactose in their life? Why do their ovaries still poop out? Why do some of them have those learning disabilities and that sort of stuff? And our presumption is that probably those 40 weeks in the womb, when these metabolic things were still going on, or when my thyroid was still low and those sort of things. And so that's one of the issues, is that even with newborn screening, we're taking them at birth, but they had a lot of time where that condition was at work before they came out. And so there's the issues of what happened in that womb. And so the thing about the 16 days with the hypothyroid is it's just real. You can just definitely show that IQ outcomes are worse if they're not treated before 16 days. Now, I don't think anybody has the data. Does it make a difference if you get them on day 2 versus day 14? So I can't imagine that 16 is like some magic biologic number that, you jump over the cliff at that point. I bet you $1 million there's still some differences that I still would love to get these kids just as soon as possible and get their confirmatory testing done, boom, get their thyroid started. Then we can take our time and worry about the rest of the stuff.
Thank you. That was excellent to hear. That's a great thing for us to tell doctors when we're talking to them. Think about what was happening before that baby was even born.
Yeah, I agree. Sounds great. Any other questions? We got another minute or so.
I just want to say thank you, guys. This was so old home day. This is so cool to see you guys, and appreciate you letting me do that and rap with my homies here for a little while. So thanks for inviting me, and good luck with the rest of the echoes. All right.
Yes, thank you. And any last questions for Dr. Schaefer leaves us? Because I have, but don't hang up, everybody, because I've got to do some closing remarks here about CEUs and stuff. Okay.
All right. I'm going to get off here.
It was great. Thanks, Dr. Schaefer.
Thank you, Dr. Schaefer.
Hey guys, bye-bye.
Okay. So that concludes our session today on the congenital hypothyroidism, and I want to thank all of y'all for coming. We love to see y'all at our next session, which is going to be on cystic fibrosis, and that's going to be on February 16th. Gail, like I told you, who's our she's our expert for doing all the accreditation. She will be putting an evaluation link in the chat, and we'll use this information on the evaluation for program planning and continuous quality improvement. And like I mentioned earlier, we have continuing education credits for free now: genetic counselors, physicians, physician assistants, and nurses. And please note that the only way to receive these continuing education credits is by completing the evaluation form. After you complete the evaluation, Gail will follow up with you via email later on this month regarding continuing education information. We'll also be sending out the session materials with the PowerPoint for both Dr. Schaefer, and Jamie. And like I said, we'd love to see you at the February 16th one on cystic fibrosis. It'll be from 12 to 1. Kira wants me to make sure I'll let everybody know that everyone signed up for this session will automatically get a calendar invite for the second session, which is on cystic fibrosis. So please look out for that email flyer to come to you. Thanks again. Is there anything else, Kira, I need to mention?
You handled it. Y'all, if you could just click on that link in the chat and fill out that evaluation. That's something
Okay,
we
well,
have to report for our ECHO
yeah, and then this is
accreditations
all,
stuff.
yeah,
So
yeah.
I'll follow up everyone with an email with that link as well, just in case you don't have a chance to look at it. But yeah,
Right.
we're good to go. Thanks for your
Okay.
participation today. Everyone did a great job. And
Yes, thanks to Jamie and Dr. Schaefer, who's left us. Appreciate all their work in doing these presentations. And we hope to see you at the next one and on February 16th and between 12 and 1. And we hope you have a good rest of your day. Thank you.
Did we lose Lori?
I think so. I was trying to get rid of, I think I got rid of
Yeah, I
everyone.
was making sure that
Mhm.
all of our participants are,
I'll text her real quick. Ask her to log back in.
yeah, ask her if she,
I out of habit just clicked leave before I realized that I was supposed to stay. I had to go back in and come back and join. I forgot.
is that Jamie?
Yeah.
I did come back though.
You came back, you did good.
I figured it out pretty quickly.
That was good.
Very good. Great job, Jamie.
Yeah, great job, Jamie. You did a good job.
And so did you, Joanne.
Oh, thank you very much. Appreciate it. What are y'all's first thoughts?
It was good. I did take a couple of notes. It'd be nice if we knew who the participants were, because I noted two of the participants were, one was my supervisor and one was another family partner. You know, so it'd be nice to know where these participants are from. And I know that what's her name? Kessie. Well, hold on, I can't remember her name. From Mountain Region.
Mm-hmm.
Christy Weiss.
Christy,
or Weiss.
yeah, I know
Mhm.
her, and she is from Mountain Region's genetic collaboration, or whatever you call it anymore.
Next time, do we want to see if people want to like put something in the chat to say like where they're, where they're
Yeah.
from and what their specialty is, or if they
I could
work.
do that. I could
That's
do that.
what I was going to suggest. Yeah.
So
Yeah, I
And,
think
let them know right away that if they have questions, go ahead and put them in the chat and we will get back to them later. You know, maybe that way people can will think of, oh, well, while Jamie's talking about this, I'm thinking of that. Because one thing I thought about, and I didn't, is was it you, Jamie, who asked about how parents feel about putting their kids on, a newborn baby on medication?
yes.
So I was trying to come up in my mind's just not working right. I think I'm getting tired again. But anyway, is that I wanted to jump in and say, that is a good lead into why geneticists and, endocrinologists, why
doctors need to have a family advocate